Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and clinical assistant professor at the Catholic University of America in Washington, D.C. And we are continuing our acute care PNP faculty series, where a star-studded team of PNP educators collaborated to bring common pediatric skills learned during your clinical rotations to you in podcast form, so that you can be confident when you encounter these situations in practice. Each episode was written by a faculty member whose clinical practice involves these skills every day, because you should learn from someone whose expertise informs the application of knowledge. These pearls of wisdom represent a practical approach founded in the scholarly literature that will help you build functional skills in a conversational way that can translate to your competency-based education. When we focus on how to do a skill rather than what to know, you'll be better prepared to apply these concepts in clinical, master a new skill set, and meet the goals of your acute care PNP practice, regardless of setting. This episode was co-written with me by Dr. Marion Malone from the University of Tennessee, Knoxville, and Dr. J.D. Murphy from Johns Hopkins University. Before we get started on enteral feeds, you may need a refresher on how to assess and manage nutrition in children with critical illness. Check out Season 4, Episode 31, Nutrition in Critical Care, to understand these important prerequisite concepts for enteral feeding. If you're all caught up, let's get started. We'll begin with a case. Kyla is a 14-year-old female with relapsed leukemia, currently admitted with anthracycline-induced cardiotoxicity. She initially presented for care due to increased shortness of breath, exercise intolerance, and leg swelling, and was found to have a 20% systolic ejection fraction on echo. Yep, heart failure. Her family reports that she's been eating less lately due to lethargy and nausea. This anecdotal evidence was confirmed with an admission weight notable for a 10% weight loss. She's currently on room air and a dobutamine drip. As the PNP covering Kyla in the PICU, you need to decide how to approach her nutritional support. Today, we'll cover malnutrition and the selection of her tube route. In the next episode, we'll select formula and initiate feeds. First, let's review malnutrition. Malnutrition, when used synonymously with undernutrition, is defined by the World Health Organization as a deficiency in the ability to take in enough energy and/or nutrients. This disease state, unfortunately, is quite prevalent, globally affecting over 20 million children under the age of 5 years, particularly in developing countries. In the United States, malnutrition is most common in children with acute or chronic illnesses. Why should we care about malnutrition? Well, particularly in hospitalized children, malnutrition is associated with stunted growth, increased infection risk, poor wound healing, more mechanical ventilation days, a prolonged hospitalization, higher healthcare cost, and increased morbidity and mortality. As a provider, it's key that you understand both how to diagnose malnutrition as well as how to address it. There are screening tools available to help you diagnose malnutrition. Ideally, you're in a center with a multidisciplinary team, which includes a registered dietitian, who will be working with you to screen patients for malnutrition. As we review in Episode 31, Nutrition in Critical Care, a pediatric-focused nutritional assessment and documentation of anthropomorphic measurements is key. This should be conducted within the first 24 hours of admission and regularly reassessed during hospitalization. The full nutrition assessment determines whether a patient can meet their metabolic needs or not. First, document the food and nutrient intake accurately, either by direct observation of what the patient eats or is receiving via supplementation, or by dietary recall via a food diary. Then calculate the total caloric and nutrient intake and compare it to their estimated needs. Calculation of the patient's energy and protein needs is typically done via equations or recommended dietary allowance references. However, these are just estimates and may not be accurate to your patient's disease state, particularly in critical care. Remember that indirect calorimetry is the best estimate of calorie needs, although this may not be available at your institution. Estimated protein and calorie needs are much higher in situations like critical illness, major surgery, infection, chemotherapy, and wounds. But PICU patients are complex, and we definitely don't want to overfeed. Based on a variety of energy and caloric needs, their requirements may be lower than that of a healthy child, which means we must reassess frequently as that patient's dynamic status can significantly change energy needs over time. The nutrition assessment will also include anthropomorphic measurements obtained on admission, so that's height, weight, head circumference, and arm circumference. And these provide objective data to use later when re-evaluating their nutrition status. Use them in conjunction with other data like input and output, labs, and diagnostic studies to get the full picture of their nutrition status. From here, the PNP and registered dietitian can work together to make informed decision about nutritional needs during hospitalization based on the child's energy needs and phase of illness. While performing a complete physical examination, there are certain nutrition-focused findings that may clue you in to protein, calorie, and vitamin deficiencies. Skin examination should look for pallor, dryness, or scaling. Evaluate the nails for fullness, mottling, pallor, or poor blanching. Hair may be thinning, dry, dull, or they could have patchy alopecia. The child may have moon facies or signs of wasting. Oral exam may note dry, cracked lips, gingival bleeding, mucositis, or a magenta or beefy red tongue. Dental caries are also common in malnourished patients. Vision changes such as night blindness may be reported, or they could have dry sclera or milk appearance to the cornea. The diagnosis of mild, moderate, or severe malnutrition would then be classified using the Aspen criteria. For Kyla, we know that she has a 10% weight loss. A calorie count of her food diary reveals that she's only meeting 20% of her estimated energy and protein needs. And based on this information, she meets criteria for severe malnutrition. Ideally, enteral nutrition would start within 24 to 48 hours of admission for children unable to take adequate nutrition by mouth. But why enteral nutrition instead of TPN? Well, for starters, it's what our gut was made to do. It's more physiologic. If the gut works, use it. It's easier and less expensive than parenteral nutrition. It's safer. There are lower infection rates and metabolic complications when we use the gut for nutrition. This occurs in part because we prevent bacterial translocation and maintain the GI barrier's integrity. There are some situations where parenteral nutrition can be used in conjunction with enteral feeds. Parenteral nutrition can supplement enteral nutrition in children who are severely malnourished or who are at risk of nutrition deterioration in the first week of feeding. Remember from episode 31 that parenteral nutrition initiation should be delayed for at least 7 days during critical illness. Parenteral nutrition has risks including infection and hepatic injury, but fun fact, patients who receive enteral nutrition plus parenteral nutrition have better overall outcomes than those who receive enteral nutrition or parenteral nutrition alone. So, how do we decide what to do? I'll walk you through a rationale that can help us decide the type of nutrition indicated. Imagine it as a flowchart as you hear the algorithm. But first, let's discuss contraindications to enteral nutrition. Absolute contraindications include paralytic or mechanical ileus, intestinal obstruction, and intestinal perforation. Relative contraindications include intestinal dysmotility, necrotizing enterocolitis, toxic megacolon, diffuse peritonitis, GI bleeding, and high-output fistulas. Children in active, unstable shock should not be fed enterally. But for those who are critically ill, while still being hemodynamically stable, enteral feeds should be considered. If you're thinking that it sounds nebulous to try to decipher who can and can't get enteral feeds based on critical illness and inotropes and the stability or instability of their vital signs, don't worry. We can help quantify that with VIS scores, and that can guide your management. A VIS score is a vasoactive inotropic support score, and it's a scoring system that measures the amount of cardiovascular support a patient needs and predicts the likelihood of adverse outcomes after surgery or other medical procedures. Evidence shows that children with low VIS scores who start early enteral feeds have a higher survival rate. So for Kyla, if her blood pressures are stable, even on the dobutamine drip, she's eligible for enteral feeds. I know I promised to talk you through that algorithm for starting enteral feeds, but first you need to understand the route options. Tubes are named by a combination of words that tell you where the tube was inserted and where it feeds. Temporary tubes are always inserted through the nose, so nasogastric, or NG, nasoduodenal, ND, and nasojejunal, NJ. Long-term or permanent tubes are surgically or percutaneously inserted by a surgeon or gastroenterologist and start in the stomach, then end in the stomach or jejunum. These would be termed gastrostomy tubes, most commonly called a G-tube, or gastrojejunostomy tube, GJ tube for short. GJ tubes have multiple lumens where one ends in the stomach, which is often used for medications, and the other is threaded into the small intestine by an interventional radiologist and used for post-pyloric feeding. All right, you know the types of tube options. Now let's decide which one to use. Imagine this like a choose-your-own nutrition adventure flowchart. Ask yourself, is oral intake adequate? If yes, that's great. You don't need enteral feeds. Continue to monitor their nutritional status with the appropriate diet order. There's an asterisk here. Some children may be able to eat and drink but aren't meeting caloric needs. So consider adjunct consults based on the child's medical history to help decide whether supplemental enteral nutrition is required. These teams include developmental pediatrics, neurology, genetics, complex care, rehabilitation medicine, and PT or OT. Moving down the algorithm, if oral intake is not adequate, ask yourself, what's the reason they can't take sufficient calories by mouth? We'll need to flesh out some options here. Is oral feeding contraindicated because they're too hemodynamically unstable or at risk of aspiration? Think about the NPO nomenclature, nil per os. Are they not allowed to put anything in their mouth because they're pending a surgical procedure? Or is eating by mouth or into the stomach simply contraindicated, but you can still feed enterally? If, after all this consideration, you find that your patient is not a candidate for using their gut, they need parenteral nutrition. If enteral feeding is allowed, then ask yourself if they have a functioning GI system. If not, they're going to need parenteral nutrition too. If the GI system works and there are no contraindications to feeding through the gut, ask whether there is a risk of aspiration. If yes, say for a patient who's intubated or has significant gastroparesis, the feeds need to go post-pyloric and feed into the small intestine to avoid reflux into the esophagus that could be aspirated. If there's no risk of aspiration, you can feed into the stomach. Lastly, ask whether the tube will be temporary or permanent. Reasons to consider a permanent tube would be if the child's not meeting oral intake goals within 3 months, or you anticipate long-term enteral feedings. Also, consider what the parent and child might prefer. The family will need to learn how to properly place temporary tubes. Conversely, they need to understand the pros, cons, and care for a permanent tube. Let's think about some examples, and you try to guess which tube the patient needs. A premature infant born at 32 weeks with low birth weight needs some time, calories, and development to feed and grow prior to transitioning to full breastfeeding. What tube would you choose? Yep, you guessed it. An NG tube is the perfect option for this neonate. How about this one? A child with congenital heart disease is awaiting a heart transplant and requires long-term nutritional support to meet the metabolic demands of chronic illness. What tube would you pick? I agree. A G tube would be perfect for this child, so long as no aspiration risks are present. All right, one last one. A child with global developmental delay who's had multiple episodes of aspiration pneumonia and has gastric outlet dysfunction. What tube would you pick? You're a total pro. I agree. A GJ tube would be the tube of choice. And what about Kyla? Her oral intake is not adequate, but she's not NPO. She has no risk of aspiration, and we think that with our treatment plan, this will be a temporary nutritional supplement. What tube would you use? I agree. A nasogastric tube was inserted and verified with X-ray to be in the stomach. It's ready to use. But what type of formula should you select? You'll have to wait for our next episode when we talk through more algorithms of decision-making for children receiving enteral feeds. I hope that you'll like, comment, and subscribe to the Peds NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks again to the acute care PNP faculty who supported the creation and review of this series, especially my episode co-authors, Drs. J.D. Murphy and Marion Malone. You can read all about the contributors and see show notes, references, and competencies at thepedsnp.com/faculty series. Share it with a colleague, pass it along to your classmates, and text it to a friend. There's no financial support or conflict of interest in this episode of the Peds NP. Follow me on Instagram at the Peds NP podcast. Email me at thepedsnp@gmail.com. And remember, this isn't just a podcast. Your patient's nutritional goals are just a few questions away. I'm Becky Carson. Take care.